Welcome everyone. My PhD thesis is Imbalance in vascular reactivity between women and men. I'm Ádám. I'm a PhD student, a dentist, and a specialist in endodontics. I work at the Department of Restorative Dentistry and Endodontics, and my supervisors there are János Vágin Beáta Keremi. My supervisor is currently Eszter Szalai, and I work with the statistician Gergely Agócs. My vision is improving the quality of female patients with cardiovascular and periodontal diseases through providing evidence-based data for personalized care. These are my two specific goals. For the first one, we have used the methodology of systematic review and meta-analysis, and the second one is a clinical trial. My first project is sex differences in macro and microvascular reactivity, systematic review and meta-analysis. Cardiovascular diseases are the leading cause of death globally for both women and men. The endothelial cells have essential roles in maintaining cardiovascular health, for example, through modulating vascular tone, angiogenesis, and so on. The age-adjusted CVD death rates and the incidences are higher in men, and one possible explanation behind this could be that the endothelial cells are targets for estrogen. Despite these differences, women have been traditionally underrepresented or even excluded from clinical trials. When we want to assess cardiovascular health, post-occlusive reactive hyperemia tests come in handy, which can be both used on macro and microvascular levels. All of these leads to the conclusion that the influence of sex on pore measurements to date remains uncertain. So our aim is to compare the pore between healthy females and males. Our clinical question: is there a difference in the pore between healthy females and males? Based around the PFO framework, where P1 and 2 are pore tests on the brachial artery and on the skin, F1 and 2 are healthy female and male, and our outcomes were change in the artery diameter and the change in blood flow, the baseline artery diameter, wall shear rate, and time to peak. And our hypothesis is that women have higher pore than men. Our initial search, with the help of the search key on the right, yielded more than 18,000 hits, and after the full selection process, we were left with 92 eligible articles. Because of the lack of time, I will be presenting only some of our results. The first outcome I would like to show is the mean baseline artery diameter, or BAD in short. The outcome measure is in millimeters. This forest plot is divided into two parts. On the left are the forest plot is stratified by the sexes. On the left, there are the outcomes for the females. On the right, there are the outcomes for the males. The overall pooled effect size, or the brachial artery mean size, was 3.57 millimeters. And when stratified by sexes, that was 3.17 for the females and almost 4 millimeters for the males, having a statistically significant difference between the two. Our next outcome is the mean relative change in artery diameter, or flow-mediated dilation. The outcome measure here is relative number, the relative change in the diameter, that can be interpreted as percentage changes, so I will just refer to that as percentages. For this analysis, 48 articles were included with about 2.4 thousand patients, and 45% of them were the females. Then again, the forest plot is divided into two parts based on the sexes. The overall mean dilation was 9.3% dilation for both women and men, and if we stratify it by sexes, it was 10.4% dilation for the females and 8.3% dilation for the males, and there was a statistically significant difference between the sexes. We've conducted a multivariate analysis for the outcome, where we included the patients sex, or the subject's sex, age, BMI, and the location of the occlusion cuff. And the analysis yielded that the patient's sex, age, and BMI were the significant predictors for the outcome. The next outcome is the mean relative change in blood flow, or delta BF. Then again, the outcome is a relative number that can be interpreted as percentage changes. Now, the forest plot could fit into well in one, so we didn't stratify it. There was about 300 patients included for this analysis from 10 articles, and the pooled effect was 536% hyperemia, and there was no statistically significant difference between the sexes. Lastly, I'm showing you the kind of the same result, but on the skin or on the microcirculatory level. The outcome is still a relative change in the circulation. There was about 80 patients included in the analysis, with half of them were female. And again, there was no statistically significant difference between the sexes, but there was a tendency for women having a higher hyperemia with about 98 to 100%. So our strengths and limitations are the following. There was a huge number of studies and participants included from multiple countries, and all of the participants were healthy and non-smokers. However, the limitations were the following. This post-occlusive reactive hyperemia test was not very well standardized, and the multiple countries come with a drawback as well, because studies often fail to report any racial or ethnic data about the patients, and also we could only work with means and standard deviations for the predictors as well for the analysis. For conclusion, we could say that the male gender has a negative effect on the extent of dilation, and for the implication for research is that the separation and also the equal distribution of the sexes for clinical trials is strongly suggested. And for practice, that the sex should be a factor considered when we are talking about personalized medicine. Our manuscript was finally submitted last week to Circulation Research. My second project is comparing the effects of heat provocation with diode laser on the healthy gingiva between men and women. Previous studies at our clinic found that there are differences in vascular reactivity between men and women on the gingiva. This gingival microcirculation can be easily investigated with non-invasive provocation tests. However, earlier or currently used tests have some drawbacks. However, this new method, heat provocation test with the diode laser, seems to be an ideal test. So our aim is to compare the heat-induced hyperemia on the healthy gingiva between women and men. Our clinical question: is there a difference between heat-induced hyperemia on the healthy gingiva between men and women? Based around PFO framework, where P is heat provocation on the gingiva, F is sex, outcome is change in blood flow in laser speckle perfusion units. Our hypothesis is hyperemia is smaller in women. If there is a difference, then we can use it with clinical implications, that if there is a difference, then we can use that for individual risk assessment for different diseases. For recent clinical trials, I'm showing you two where they carried out a pore test and they applied vasoactive molecules on the gingiva, and both tests yielded that males had more prolonged and pronounced hyperemia on the gingiva. So as per summary, these were my two ongoing projects. The first one is submitted, and the second one's planned submission date is August 2027. As per additional activities, I'm a full-time clinician at my department where I'm teaching 3 subjects, and I presented my first project's abstract last year's Semmelweis Symposium. To know is to know that you know nothing. That is the meaning of true knowledge. Thank you for your attention.
I would like to ask that in your first study, it was not clear for me that for the female and the male, for this separate, I could not read it. So there was different studies, or you have 2 entries from the same studies, or?
These are from one, and so these results are from individual studies, and all of the studies were 2-armed, having both female and male participants, and we stratified their outcomes for males and for females.
So because there are a lot of studies, so you have not included any additional information that the same study has the 2 arms.
No, so sorry.
No, okay.
Both of them were 2-armed. The additional columns on the left just tell us information where was the position of the occlusion cuff at the provocation tests. Then the number of participants, the mean age, and their mean BMI.
Mm-hmm. And we see that there are a lot of number in the row heterogeneity. What different, so a lot of things in the heterogeneity row. So what are the meaning of I squared, tau, and p? Why we have this lot of values here?
So the tau gives us the size of the value or the outcome of the heterogeneity. Right now it says 0.001. That can be interpreted that the heterogeneity equals to 1% to our outcome, and the I squared gives us how much is that contributes to the total heterogeneity, and the p-value gives us whether is it even there, so is it even significant or not.
And in the random effects model, where we are assuming that there is heterogeneity, is it the meaning for the p-value for the heterogeneity?
Well, yes.
In my opinion, no, but okay, no. It's my opinion. Okay, and there was some other question that when you mentioned that you did a multivariate analysis, have you checked the interaction of it? So, for example, for combining 2 of the looked factors, or you looked only separately?
Well, we have done it separately because we had to. So when we were comparing the age, the mean age effect on the flow-mediated dilation, we had to average for the BMA values and vice versa.
So it was no combination of them. Okay, thank you.
Congrats, Ádám. I have 2 questions. At first, you mentioned that the cuff position is a confounder. So why is it?
Okay, so these post-occlusive reactive hyperemia tests, or FMD tests on the brachial artery, the test itself is a reactive hyperemia test, so there is an occlusion at some level of the circulation. Here we investigated the upper arm occlusion and the forearm occlusion, and they have found out earlier that the lower arm occlusions, so where the occlusion cuff is on the forearm, there's the ultrasound probe on the brachial artery and the antecubital fossa. In this setup, they have found that most of the effect is caused by nitrous monoxide or nitrous oxide, but when they occlude it on the upper arm, And below the occlusion there is the ultrasound probe. They have found that only about 70% of the dilation is originated from nitrous oxide. Some others are originated to endothelial-derived hyperpolarizing factor and myogenic responses. And also, we wanted to carry out this analysis because they also said that the extent of hyperemia or the extent of dilation is bigger than with forearm occlusion, but we didn't find a statistically significant effect for that.
Thank you. And my other question would be a little bit practical. You mentioned the laser speckle. Mm-hmm. And my question would be that do you use that in everyday practice in your department? Because I know that your department has the laser speckle. Mm-hmm. We doesn't have. We would use it for flap circulation measurements, but do you use it in the practicum as well, or just for the trials?
For everyday practice, no, we do not use it just yet. Just for clinical trials.
Thank you.
If we could go to the slide where you have the conclusions for the first study. So, I wonder if you could be more specific with these, because the implication for practice that sex should be a factor for personalized medicine does not sound very specific, you know, and it doesn't seem like your study was needed to conclude that. And then also implications for research. I wonder if that's actually true, because you don't need equal distribution of men and women in each study to study sex-specific effects. So I would challenge you on those conclusions, and I believe you can do better. So maybe we could try and you know, summarize, or you could try and summarize your project for us, this first study, and maybe we can try and conclude something more useful and maybe more accurate.
Okay, thank you. My implication written there for the research is separation and equal distribution of sexes for clinical trials is strongly suggested. We came to this conclusion because of two things. There was a review article from about 2017 where they have analyzed many clinical trials about cardiovascular diseases, and there was about 35 to 40% of the patients in those articles that were women, and these articles were conducted from 2010 to up to 2017. So there's a huge discrepancy between the number of patients based on their sex. And also the separation of sexes is needed. Well, during the selection process, when we were analyzing the full text, so there was 1,800 articles we had to look through, and most of them, about 1,200 papers, failed to mention any sex distribution in these articles. So, this is why we strongly suggest this, and these points are challenged also in our manuscript. Yeah. And the
okay.
other...
I'm sorry to stop you briefly, but your implication for research doesn't say that. It says something different. So maybe you can fine-tune that. Just like you know, because here you say equal distribution of sexes is needed in clinical trials. That's not what you just said. You just said that reporting of okay, so, and that I can agree with. This not, you know. Okay, so let's hear the second part of your answer, please.
Well, for the second part, I wanted to talk about the implication for practice. And today's guidelines do not about cardiovascular disease management, do not really talk about that whether females need different medicine, different dosages of the same medicine, and if there's fundamental differences between the sexes at the level of their endothelial function, then maybe they should look into that as well. I mean, I know my topic is more about basic research, so whether there will be truly clinically relevant effects, or they can use it for anything, it's up to the future. We cannot really tell, but it gives us great fundamentals for that. So whether my conclusions or my results cannot really tell that you have to look for different approaches when you are treating sexes, but gives us an insight that we should look into this when we are developing these guidelines and other.
Sure. I was hoping here that you could summarize your study. So from your research question, from the rationale for the research question itself, and then, you know, in a sentence, what did you find? And just, you know, try to, like you would tell your neighbor, you know, what were you trying to study? What did you find? And what conclusions, clinically relevant conclusions, can you draw from it? If you could try that, maybe.
So briefly, our question was, is there a difference between vascular reactivity between men and women?
Okay, so the neighbor doesn't really understand what's vascular reactivity.
Okay, so our question is whether there is a difference between men and women in their cardiovascular functions, maybe.
So what is vascular reactivity?
Well, it's the ability of the vasculature to respond to different provocations, to respond to different effects.
Okay, and in what way can vasculature respond?
By the vessels dilating or expanding, or the blood flow increasing.
The what, sorry?
The blood flow.
Blood flow, okay, yeah.
Or the time it takes to even react to that insult.
Great. And what did you find in terms of differences between men and women in these parameters?
Okay, so in regards of the dilation, we have found that there were about a 2% difference between men and women, or direct comparison, this equals about 20 or 25% between the sexes. In blood flow, there was no statistically significant difference found, but this should be taken with, there are many parameters that we could not control for. For example, the oxidative properties of the supply tissue that was blocked from the circulation, the personal fitness status, and something like this. We have also analyzed the time to peak, but because of the lack of time, we didn't show it, and we have found that women react faster to these insults. They reach the peak dilation faster than males. And yeah, I guess I've addressed all of the previous points.
Okay, so one medical condition that I can think of where this might have relevance is, for example, rosacea. Yes?
Yeah, it can, yes.
Okay, so have you looked at the results and what implications you could draw from your results in terms of rosacea as a medical condition? I mean, have you thought about it?
Well, not rosacea in particular, but as far as I'm concerned, rosacea comes as well with endothelial dysfunction. And if that's the case, then these patients would experience lower flow-mediated dilation or lower skin hyperemia.
So I'm not sure about endothelial dysfunction. I'm not convinced. I don't know of it, but I'm not a dermatologist. Does anyone have this specific expertise? No? Okay, but thank you very much. This helps me, and I hope that you will try and draw more meaningful implications from your work. Thanks very much.
Thank you.
Just one question regarding your second project. I think that's the clinical study. You mentioned this laser speckle. I don't have it at my department. What is laser speckle actually?
Okay, so laser speckle contrast analysis is the whole name of the process. Laser speckle, okay, let's start from when we illuminate something with laser, there will be backscatter. And these laser backscatters will interfere with each other. And when it's backscattered from moving particles, for example, in our case, the moving red blood cells, the more moving particles or the faster moving particles, the more interfered the pattern will be. And this laser speckle contrast analysis will render this interference to a heat map. And this is the laser speckle contrast. And this is analyzed by the system itself.
Okay, so you make pictures with this device,
well,
if I understand it, and then you analyze it?
Pictures or videos, yeah.
Videos,
yeah.
Okay.